It's almost 5 minutes past. It's almost 5 minutes past 6 o'clock, so we'll make a start. So I'm not sure if any of you had attended last week's session, but I'm Kevin Phillips, one of the radiology doctors here in Aberdeen Royal Infirmary. So this is the second part series of the GU interventional radiology talk. Last week's emphasis was mainly on CT and ultrasound guided biopsies and drains with a short snippet on fluoroscopic guided drains. This week I was given the theme and the topic of nuclear medicine in relation to genital urinary radiology and interventional radiology. So I've tried to select cases specifically that will tie into a bit of the nuclear medicine modalities that we use. So like last week, there'll be themes running throughout the lecture slides, and it'll be largely case-based. So I'll get you guys to vote as we go through the case studies. I've structured it differently this time, and hopefully we'll get a bit more interaction. All right, so this is largely the structure of the talk over two themes with nuclear medicine, a specific fluoroscopic study called micturating cystourethrogram, also known as MCUG or VCUG, and the use of CTU. And we'll have a review of normal male urethral anatomy and some of the pathologies associated with that. So the first case, I'll let you guys read this for a minute or so. We've got a 2-day-old neonate male patient with right-sided abdominal mass, is referred for ultrasound of the abdomen. Ultrasound demonstrates an enlarged right kidney containing multiple non-communicating cysts of varying size with little normal renal parenchyma. So the question is, what is the most common associated abnormality of the opposite kidney? So what would we expect to see in the left kidney? So this is quite a challenging question, but if you cast your votes just now, whether you'd say option A or B, so look at your guys' chat here. So yeah, just put in your votes for A or B, what you think. So I suppose this is quite a challenging question. I'm not seeing any responses from yourselves. So what we'll do is we'll go on to the explanation of this. So essentially, let's see here. So here you've got an ultrasound of a 2-day-old patient. First two images are ultrasound images, and that shows these well-defined cysts essentially scattered throughout the kidney. They're of varying size and shape. There's no solid components or complexity associated with these cysts that you see, largely confined to the kidney. And you're not seeing much of the renal parenchyma. The renal parenchyma is quite thinned. You also notice that the patient had a fetal MRI. And again, you appreciate these cysts arising from the left kidney. So you see these well-defined high 2 signal cystic lesions arising from the left kidney. And for reference, here is the actual normal kidney. And the volume of the amniotic fluid is within the expected range. So you can infer that this kidney, this right normal appearing kidney, is functioning as it should be. So before we move on to a specialized type of nuclear medicine study, which is called MAG3, we'll have a look at what normally happens. So this is a specialized type of study that looks at renal function, and essentially the radioisotope is injected. So MAG3 radioisotope is injected, and this is excreted through the kidney. And you can record the amount that is excreted over a certain period. and you can see as to whether there is variation in terms of function. So the kidney's ability to filter this radioisotope. And you can see here in this diagram that both kidneys are of equal function. So they're almost 50% essentially. So this is what a normal MAG3 study looks like. In our patient, as you can see here, there's only one kidney that is showing good excretion, so therefore shows good output of MAG3. Whereas the opposite kidney, the pathological kidney on the right, shows no uptake whatsoever. So it kind of suggests that this kidney has no real functioning renal tissue, but largely is composed of several cysts. So yeah, so this is essentially a specific type of study that we do in pediatric radiology. So these are some of the combined images. So you see the ultrasound scan, see the MRI, and you see like a animated image of the pathology here with multiple cysts, very little renal parenchyma, and a very abnormal looking MCUG. So if I got you guys to maybe mention what diagnosis this is. So if you were to type in the chat box. So polycystic kidney, yeah, that's a good thought. Yeah, so polycystic kidney is certainly a good differential. Unilateral polycystic kidney is quite rare. You'd rather often have bilateral polycystic kidney disease. And certainly, you're certainly thinking along the right lines in terms of, cystic renal disease in neonates, or that is seen in the antenatal period. So some of you may have heard of this condition. I kind of purposely picked this because it was quite challenging. So let's see here. So multicystic dysplastic kidney. So this is a condition where, as you can see here, the kidneys undergo several cystic formation, largely replacing the renal parenchyma. It's oftentimes diagnosed antenatally during like an ultrasound scan, or it can be picked up during the neonatal period. I think if it goes unrecognized, not only can the patient have problems of things like recurrent cysts infection, but they can also have problems with the opposite kidney. So oftentimes the opposite kidney is normal. The bilateral form is quite rare, and it's quite fatal because you essentially have no functioning kidney, or renal function, should I say. So those with a unilateral, the unilateral form tend to, live into adulthood and do quite well relatively, as long as there's no real associated complications. So with that brief overview of this cystic renal disease, the question was, what would we see in the opposite kidney? So if this is the abnormal kidney, what would we see associated with the other kidney that is functionally normal? So if you just type in your options now, so some of you are going for A. So Sally, you've gone for B. So Sally, can I ask why did you go for option B?
Honestly, just a guess, because everyone else was going for A.
Well, that's a certainly good line of thinking, and you're right. So this type of condition is associated with reflux disease. So vesicular ureteric reflux. So urine refluxing from the urinary bladder up towards the kidney. And the reason why this is important, remember I said that this cystic kidney is virtually non-functional. So you want to try and protect the opposite kidney as much as possible. And we'll talk about the vesicular ureteric reflux and its associated complications. But in terms of grading, you may or may not have seen the grading classification. So this is something to be, to know, especially once you get into radiology and things like that. Mainly because you'll be doing certain studies that will assess the actual grade of the reflux, and this has treatment and management implications for the patient, be it pediatrics, oftentimes, largely because if you have quite bad reflux and that goes on for quite some time, then with time you're going to have recurrent infections, pyelonephritis, renal cortical scarring, reduced renal function, and ultimately a degree of renal failure. So this is what the aim of this is trying to prevent further reduction in renal function of the opposite kidney. So we'll just go through the grade here. So that's obviously just a normal appearing kidney here with no reflux. Grade 1 is reflux to the ureter. It could be to the mid-ureter, but it's confined largely to the ureter. It doesn't extend up into the renal pelvis or the calyces, whereas grade 2 does extend to the renal calyx or the renal pelvis, but without dilatation. And in grade 3, you get mild dilatation. Again, reflux up to the calyces. And from here, the severity of the dilatation just becomes worse. So you get mild in grade 3, moderate in grade 4, with blunting of the calyces, as you can see here. And the ureter becomes a little bit more tortuous, as you can see. And in grade 5, which is quite severe, the ureter is significantly tortuous, very dilated. So you've got a hydroureter and quite a pronounced pelvic calyceal system, as you can see here. And you'll also appreciate that the renal cortex is relatively thin compared to the previous less severe grades. So this is the grading classification, and these images are obtained from Radiopedia. So you can always reference this article in your own time. So when it comes down to evaluating reflux disease in children, there's a fluoroscopy study called MCUG, also known as voiding cystourethrogram. Essentially what this involves is putting a catheter into the urinary bladder and then injecting contrast into the urinary bladder, allowing it to fill. Depending upon the size of the urinary bladder, you can put in about 150 to 250 mLs. I do a lot of this stuff for adults for post prostatic surgery and things like that, just to make sure there's no anastomotic leak. But in children, obviously we're trying to assess as to whether there's reflux. So you fill the urinary bladder, as you can see here in this middle image, and then you either take out the catheter or you deflate the balloon, so you can then allow for the patient to pass urine or pass contrast in this case. So as the contrast is excreted or eliminated, you should see a reflux either on filling of the urinary bladder or on emptying of the urinary bladder. So this is a normal study, so there's no evidence of reflux here. If I showed you an abnormal study, for example, here, so again, catheterize the urinary bladder, fill up the urinary bladder with contrast, and as you're doing that, you see bilateral reflux disease involving both kidneys. So this is a different case. This is just an example. So you see reflux of contrast into both the ureters up to the renal pelvis and to the level of the calyces here bilaterally. And as the patient voids or urinates, there's that further reflux up into the collecting system, as you can see here. And it's it's moderately dilated, so I'd classify this as a grade 4 reflux. So in our patient has unilateral disease. So we would see something like this. So if the diseased kidney, if the cystic kidney is on the left-hand side, then we would expect to see reflux in the opposite kidney. So this isn't a child, as you can probably tell just by the skeletal morphology. I was trying to find a pediatric case on Radiopedia that would show unilateral findings, but I wasn't successful. But this is just an example of a unilateral reflux. And another point is that you can have unilateral reflux. You don't necessarily have to have reflux in both systems. So this is a summary slide of the images combined. Like I said, these patients do relatively well as long as the opposite kidney is protected with regards to, minimizing the reflux disease and things like that, and just minimizing risk of infection and stuff. But the outcome is generally pretty good. A couple of things about the cystic kidney itself. As the patient ages, these cysts can become smaller. As you can see, they are of varying size, and that they can cause mass effect to adjacent structures, be it to adjacent vasculature, and that can result in a secondary hypertensive effect. So these patients may have uncontrollable hypertension or drug-resistant hypertension secondary to the mass effect. And yeah, in some very rare cases, some of these cysts can undergo malignant transformation, mainly because there's always going to be an element of inflammation involved in some of these cysts. So that's case 1. If we go on to case 2, so I'll let you guys read this. So we've got a 7-year-old girl presents with a history of continuous dribbling incontinence. On imaging, she is found to have unilateral duplex kidney, urethral duplication, and ectopic ureter. Which of the following statements regarding ectopic ureters and urethral duplication is true? So this is again, these questions are intentionally challenging to try and kind of structure the talk to incorporate a bit of nuclear medicine and interventional radiology at the same time. So if you want to put in some of your votes now, I'd be kind of curious to know what you'd put for this. Okay, very good. So yeah, some of you guys are going for option A, which is good. And as long as you had a go, it's like I said, these are difficult questions. So I'm glad that you guys are having a go, which is good. Right. So we'll talk about this case, and we'll talk about the image here that's on the top right as well. So this type of image is quite an old-fashioned study. So it's called an IV urogram. So essentially, water-soluble contrast is injected, and essentially you take an X-ray, and when the contrast has reached the collecting system. As you can see here in this image, you see 2 renal pelvic systems here that join kind of midway to form one single ureter. Now, this old-fashioned study has been largely replaced by this study, which is a CT, and this is a specific type of CT in that the timing of when the CT was acquired, there's a specific time so that we can allow for contrast to filter through the kidney and into the collecting system. So what we see here in the upper pole, we see a very dilated system with a very narrowed renal cortex, and we see a relatively normal appearing lower pole kidney. For reference, this upper pole, here is the upper pole of the opposite kidney. So you can see that this is very dilated, and it has been dilated for quite some time because the renal cortex is now thinned. In the pelvis, as we follow the ureter, we have one single ureter here on the left. We have another here on the right, but we have a dilated tubular structure just here behind this contrast-filled normal caliber ureter. So this right here is the lower pole ureter that empties distally, and this behind, which is dilated, is the one that is connected to the upper pole of the kidney. So this is a CT urogram. So this is a more detailed study in terms of, looking at the collecting system in more detail. And ultimately what we're talking about here, we're talking about duplex collecting systems. Now, you'll see this during your, you'll see this in patients during your pediatric rounds or pediatric placements and things. So this is one of the most common renal developmental abnormality, where you've got two collecting systems leaving the kidney and having two different entry points, the urinary bladder. Now, the reason why this is important is largely because of their effects that they have upstream. So, for example, here you have the upper pole of the kidney that enters the urinary bladder inferiorly and medially to the ureter filtering the lower pole. So this is the lower pole ureter entering the urinary bladder where you would normally expect it to enter, while the upper pole, so the duplicated ureter, enters inferiorly and medially. There is also an association with this in that you see this element which is quite dilated. So this is a urethral, and this can result in an element of obstruction. So hence the reason why you've got a dilated system upstream. And of course, like with anything, if you've got a blocked system, increased risk of infection, pyelonephritis, chronic kidney injury, with clinical scarring and reduced renal function. So what happens here is that there is usually an anatomical distortion to the function of this lower pole ureter. And what happens to this lower pole ureter is that you get reflux. So the upper pole is obstructed, and the lower pole you get a reflux, essentially, because of the urethral. And you see the urethral in about 60% of cases. So it's not uncommon, especially in these conditions. One interesting thing just to be aware of about the upper pole entry point of the ureter is that it doesn't have to enter the urinary bladder. You could have the entry point further down in the prostatic aspect of the ureter in males, and we'll talk about the anatomy of the ureter shortly, or urethra, should I say, shortly. Or you can have the upper pole entering the vaginal vault in females. So yeah, so just get these slides and these images in your mind, and that helps you differentiate the two. So again, this is the nuclear medicine study with regards to the MAG3, which looks at renal function, and you can appreciate that the upper pole of this left kidney has essentially almost zero renal function, almost like just below 2%. There's reduced renal function of the left lower pole, and this could have been due to, again, reflux disease, so chronic reflux with infection and an element of scarring. And you appreciate that there's a compensatory effect, there's compensatory renal function greater than 50% of the right kidney. And this is depicted by the graph itself. So you've got a compensatory effect of the right kidney with regards to its renal function, a relatively reduced function of the lower pole of the left kidney, and virtually no function at the upper pole. And here is an example of a very dilated system to the upper pole, and you can appreciate a very relatively normal appearing lower pole ureter and collecting system here. So the thing about having a very dilated system, especially at the upper pole, is that it can cause mass effect to the lower pole, to the collecting system of the lower pole. And you sometimes get this classic sign called the drooping lily sign. So here obviously a picture of a lily, and then this is a study where we've done a micturating cystourethrogram where the patient voids, and then you see the reflux, and you see reflux of contrast all the way up into the collecting system. And the drooping lily sign is largely because of the mass effect caused by the obstructed and dilated upper pole system. So if I showed you this study, so this is an MCUG, again, you fill the bladder and you see the reflux, and you may appreciate that, this isn't an ideal image, but we get a drooping lily sign here on this study. It's not as nice as the previous image that I showed you, which is right here. But yeah, but this child did have a drooping lily sign secondary to a dilated upper system. So if we look at this question again, I'd like you guys to cast your votes, and hopefully you learned something from our little case discussion. So which one would it be, A or B? Let's see what you guys say. Yeah, so a bit of a mixed, yes, Sally, you got it right again. So, but yeah, so certainly it's B. So the upper pole moiety, okay, so the upper collecting system is associated with a urethral, which we did say that it is, whereas the lower pole moiety is associated with the reflux. So if we just go back to that image, so the upper pole is associated with the urethral, and the lower pole, because of its anatomical distortion, due to the urethral, is prone to a reflux. And remember the location of the entry point of the upper pole moiety. So it's going to be inferior and medial in relation to the entry point of the lower pole ureter. So yeah, option B. So moving on to case 3, I'll let you guys read this for a second. So we've got a 22-year-old male front seat passenger is admitted following an RTA. On examination to A&E, blood is noted at the external urethral meatus, and there's swelling of the penis. A urethrogram is performed, which demonstrates contrast, leaking below the urogenital diaphragm only. And the question is, what type of urethral injury does this represent? So cast your votes now. A or B. So good. So again, so mixed responses in terms of the options, which is good. So hopefully you'll learn something from this discussion of case 3. So a review of normal anatomy. So the male urethra is obviously longer than females, which makes it prone to pathology and injury. You can divide this into 2 segments. You've got the anterior and posterior, which is composed of the penile urethra, bulbous urethra, whereas the posterior segment is made up of the membranous and prostatic urethra. So does anybody know what study this is? So not many centers do studies like this. And certainly you can get a lot of information from performing things like this, especially when you're trying to answer specific questions. So this is a retrograde urethrogram, and what this involves is catheterizing the tip of the penis by a relatively small catheter, 8 French or 10 French, only inserting it maybe 1 or 2 inches and just slightly inflating the balloon. Essentially, what you're going to do is you're going to inject contrast, about 10 to 20 mLs of contrast through the catheter and then through the urethra here. And what you're trying to determine is you're trying to see if there's any elements of stricture, whether there's focal stricture or if there's a leak. So if we looked at the anatomy of the previous slide, so here you've got the anterior segments, which is the penile and bulbous urethra, and the membranous and prostatic urethra. So this is the penile urethra, bulbous urethra, over to the membranous urethra, and then to the to the prostatic urethra here. And this red line is the urogenital diaphragm, and that's what separates the posterior segment and the anterior segment here. So when it comes down to imaging the anterior or the posterior segments, you do different studies and different imaging techniques to help answer the question. So for example, I would do a study like this, which is a retrograde urethrogram, which is again injecting contrast through a catheter from the tip of the penis to look at the anterior aspects of the urethra here to see if there's any narrowing or stricture or leak or anything like that. So this is an antegrade. So this is basically where contrast is injected from the suprapubic catheter straight into the urinary bladder. And the patient is then asked to void to look at the posterior segment of the urethra. And as you can see here, you see contrast leaking from this posterior segment of the urethra, which is going to be part of the prostatic and the membranous urethra. Okay, and for reference, this is the bulbous, and down here is going to be the penile urethra. So what else other than a significant leak do you see in this image? So if you just type in what you think has happened here. What do you guys think of the bones? So you got a couple of fractures in relation to the bony pelvis. So fracture here, here, and I believe fracture possibly there, and a fracture here as well. So this is obviously a trauma case that has caused an injury to the posterior aspect of the urethra. So the prostatic urethra and the membranous urethra, and it's caused local leak of contrast here. So when it comes down to looking at urethral injuries, there's ways in which we communicate our findings. And one way we do that, amongst the urology team is to describe obviously what we see and, the location, but there are grades of injury for urethral injuries. So we'll quickly go through this. So grade 1, you don't have a tear or rupture, but rather you have stretching of the membranous urethra just here. And for reference, this is the urogenital diaphragm. So anything below that will be the anterior segment. So this is the penile urethra, and this is the bulbous urethra up to the level of the urogenital diaphragm. And then from that point onwards, it is the membranous urethra just here, and then it becomes the prostatic urethra. So that's grade 1, which is stretching, but no rupture. In grade 2, you've got rupture of the membranous urethra. And this is actually an example of grade 2. So you've got leak of contrast all above the urogenital diaphragm. Grade 3, you've got disruption of the membranous urethra, but also disruption of the urogenital diaphragm. So to try and differentiate between these two, type 1 and type 3 is quite challenging. And certainly involves, experienced eyes to determine the two. And grade 4 is a rupture at the neck of the urinary bladder. And here, grade 5 is a rupture below the urogenital diaphragm. So this is just purely anterior urethral injury involving the bulbous urethra. So here's an example of grade 3. So if we look back at the grade, so this is grade 3, so rupture of the membranous urethra and the urogenital diaphragm. We see leak of contrast essentially into the extra peritoneal space and then towards the inguinal canal here. So I think this was actually a gunshot wound to the groin, and you can see several locules of gas, lots of free contrast that's within the pelvis and also towards the inguinal region here, and certainly bony fractures as well. So if you look at this question again, why don't you guys cast your votes as to what you think this could be? And I've purposely kept the Goldman classification on this slide to help you figure out what it is. So just cast your votes now. So yeah, very good. So most of you guys are going for A. Yeah, so I think the clue here in the question is that you've got contrast leaking below the urogenital diaphragm. Let me just minimize my section of the typing bits. So contrast leaking below the urogenital diaphragm and swelling of the penis here. So if we look at the classification system, so below the urogenital diaphragm, and if you've got leaking of contrast below this, you're going to have swelling of the penis. So this would be classified as a type 5 injury. So purely anterior urethral injury here. So that's type 5. So good. So we've certainly talked about several different modalities, as you can see here, compared to last week where we just kind of focusing on CT and ultrasound, kind of dived into a little bit more nuclear medicine studies, particularly looking at renal function with MAG3. Some, non-vascular intervention that we do, be it in pediatrics, but we also do it in adults for different reasons, such as MCUG and a retrograde uretrogram and a CT urogram to assess the collecting system. So as before, certainly radiology, I know many of you are thinking about applying to interventional radiology or radiology in general. Certainly radiology plays quite a central role in the diagnosis of patients and kind of progressing that diagnosis and differentials, and also playing quite a central role in the treatment and management of patients. And so as before, certain reading material, specifically with regards to urethral injuries, RadioGraphics has an online presentation that's really well done. It has some really good examples. And I know certainly, like I said, not many centers do studies like this. So I think having some high quality images presented to you in a online presentation format, which is completely free, is certainly worthwhile. So again, something that you can always look into before doing your taste sessions in radiology. So, and that's it.
Very much, Dr. Phillips, for that talk. Does anybody have any questions? Doesn't look like it. So if everybody could please fill out the feedback form on Medal, that would be great. I think you'll receive an email about that shortly. Thank you for coming, everybody.
Yeah, and thank you for everyone for listening, and hopefully this presentation wasn't too boring. It was quite difficult to combine. It was quite difficult to combine nuclear medicine related stuff to interventional radiology, but somehow managed. Very good. Good.
More questions are coming in, so I think we'll just leave it there. Thank you very much. I will end the meeting now.
Thank you.
Thank you.
Thank you, everybody.